It's a lot to cover in 10 minutes. I want to thank the organizers for including me, and I appreciate being here. I'm reminded by a statement that it was once said that the most dangerous aneurysms are the small ones because if you don't fix them, someone else will. So I'm not going to go through all of the specific criteria, but we'll try and address some of these. These are my disclosures. So again, there's a certain amount of repetition that's taken place, and you'll see some overlap between all of us, I think, as speakers. Clearly, the historical treatment for abdominal aneurysms was, in fact, the surgical procedure, and it took place for nearly 5 decades. And as the technique became perfected, it became the standard of care, and implantation of aortic tube grafts and bifurcated aortic grafts became the essential skills for vascular surgeons. And it was really the development of expertise and proficiency that became a routine part of surgical training for vascular surgeons. So now it's been nearly 3 decades since Parodi and colleagues published the concept of transfemoral intraluminal graft implantation with the exclusion rather than the replacement of the aneurysm. And since then, open surgical repair for AAA, the standard for a preceding half-century, has basically been surpassed by endovascular repair. Compared with open aneurysm repair, patients who undergo EVAR enjoy shorter length of hospital stay, fewer complications, and lower in-hospital mortalities. Now, the evolution of EVAR, the device evolution implant experience, has also been associated with marked reductions in type 1 and type 3 endoleaks, the need for reintervention, and freedom from aneurysm-related mortality. The commercially available EVAR endografts are low profile, they're relatively easy to deliver and deploy, they're durable, and they fit a broad range of anatomy, but not all anatomies. And currently in the U.S., there are 4 manufacturers of EVAR devices that are approved: the Cook Zenith Flex and the ZFen device, the Gore Excluder device, the Medtronic's Endurant 2, and then Endologics has both the AFX and Ovation device. And many of you who do this procedure are well familiar with these devices. You probably all have a favorite. I know I do. So, and largely it's the one that we use most commonly to become comfortable. Well, what's the general data with regard to utilization? National input sample revealed a dramatic shift from open surgical repair to EVAR, and you saw a previous slide. In 2000, 5.2% of all AAAs were repaired by EVAR, 5.9% of unruptured, and 0.8% of ruptured. By 2010, 74% of all abdominal aortic aneurysms were repaired with EVAR, almost 78% were unruptured, and almost 40% were ruptured aneurysms. So the drivers for continued growth of EVAR volumes includes patient preference, outcomes, and market forces. And hospitals do enjoy the perception of being engines of innovation, increasing their market share by offering cutting-edge technology. Well, what about patient selection? The anatomical suitability remains the critical limitation of EVAR, and it's the primary mode of failure. Operators frequently push the boundaries of the devices to treat complex anatomy, and the application of EVAR outside the instructions for use, either because of patient demands or unwillingness to offer surgical repair, has resulted in increased complications and device failures. And again, you saw on a previous slide the data that shows the continued expansion in these patients where you fail to follow the IFU. This was a review of 10,000 patients that revealed only 42% had anatomy that was compliant with the anatomical IFU guidelines. The 5-year sac enlargement rate was 41%, an outcome that was significantly higher in patients who were treated outside the IFU. And patients with more than 2 off-label aortic neck features, which were defined as non-cylindrical, angulated, short, or enlarged, they underwent more intraoperative adjunctive procedures and had much higher rates of intraoperative endoleaks and ultimately all-cause mortality. What about anatomy? The anatomy of the aortoiliac arterial segment is vital because it determines the suitability for and the durability of endovascular abdominal aortic aneurysm repair. Now, patients have been shown to derive the greatest limb patency and long-term benefit after EVAR if the evidence of perioperative complications and secondary interventions are minimized. So there are specific morphologic characteristics that you need to look for. Several morphologic criteria must be assessed preoperatively to determine anatomical suitability. Now, the anatomical suitability criteria for EVAR are inconsistent. They vary between 25 and 66% and most often refer to the most liberal anatomical restrictions for each device. Then again, this is why you become familiar with one device and you use it frequently so that you understand how that device is going to react within a given anatomy. And reasons for this variation is that many subjective features determine suitability, such as wall calcification, luminal thrombus, neck suitability. And it gets beyond the scope of this talk to talk about all of these various things, but many of these things have been studied extensively, and both in longitudinal as well as mostly longitudinal studies that have clearly demonstrated their significant impact. So again, imaging has changed dramatically since we started doing endographs, three-dimensional imaging. This is a straight line, and again, you saw this from the planning. Centerline imaging, this is a TeraRecon. You can get the dimension. You see the average diameter of the aortic neck in this case. And in fact, this is very helpful in determining how you're going to plan your device, what type of device you're going to use, and the anatomical features that, in fact, may contribute to your decision to do it with a pre-close technique, whether you do it with an open surgical access, depending on the degree of calcification. All of those things can be derived from these types of centerline measurements. So there have been lots of changes in the devices. They have undergone changes in terms of the design and the materials used in order to achieve a lower profile and to therefore increase the number of patients that are suitable. You have to go back a few years, but in the beginning, many of these patients, the devices were very large, the iliac arteries were too small, and the access was a critical issue. Initial reduction in profile was achieved by making devices modular. There have been also changes in the fabric used for the graft and the types of metal used for stents. There are a number of devices that are currently available with profiles that range from 14 to 20 French outside diameter. And again, the safety and effectiveness of these devices has been assessed in a number of studies. Chris Munson et al. Determined that lower profile aortic stent grafts could increase the proportion of patients that were suitable candidates for EVAR by up to 60%. What are some of the new devices? There are many EVAR devices becoming available or currently in the pipeline that promise to improve on the availability. Low-profile devices by refining the delivery system and further reducing the profile. Lombard has developed the Altura system, which is a unique bilateral D-stent design that simplifies the procedures made of braided nitinol. It does provide for improved flexibility and conformability to the vessel geometry. The device is 14 French. It does have CE mark in Europe. It's not yet currently available here commercially. The Triovance abdominal stent graft from Bolton incorporates a Navitel delivery system, which has proximal and distal fixation and is really designed to allow for repositioning and accurate placement. So I'd leave you in conclusion, low-profile devices have the potential to change the way we plan and implement endovascular repair of abdominal aortic aneurysms. The results of the devices currently available on the market with the lowest profile are encouraging and demonstrate that favorable midterm outcomes can be achieved using low-profile technology in patients with unfavorable iliac anatomy. And these devices may have a particular role in the treatment of patients who tend to have smaller access vessels, such as Asians or female patients. And clearly, further studies are required to substantiate these results and to assess longer-term outcomes. And I thank you for your attention, and I'll be happy to take any questions.
What is your favorite device? Just as you mentioned.
So we do use a number of devices. At our institution, we currently are, I would say we are a Gore shop. We tend to use the excluder device. We've been involved in some of their trials. It has been a device that we're really quite comfortable with. I will tell you, in the middle of the night when you're faced with a contained rupture or a patient who's hypotensive, you want to be absolutely certain that you know how to use the device and get it into place. And the last thing in the world you want to do is open up the IFU and say, well, now, how do I do this again? So I think that that's part of it. I mean, there are some favorable issues with regard to pricing, and again, we have a relationship with Gore as a result of that, and so it's worked out well for us. We do use other devices. We've certainly used Endologics. Again, we've been in a trial. We were into the Bolton trial. So I think that there are clearly certain anatomies. We do use the Z-Fen device for our fenestrated devices, having made the homemade devices, which were clearly not ready for prime time. So, but I would tell you, we predominantly, Gore is probably our predominant device. Thank you again.
And next is Dr. Hanau, polymer approaches to EVAR, Ovation stent graft, and Nelix endobags.